Okay, thank you. So I think that is the title of my talk. When you see a patient coming to your office with bleeding, at the back of your mind, the formula diagnosis is going to, and you see a massive uterus, it's going to be a fibroid. I think you should, at the back of your mind, think whether it's a sarcoma. So can you put into presentation?
Okay.
Yeah. Okay, so these are the main objectives for my talk. That's to understand the epidemiology of future sarcomas. Then I'm going to highlight some clinical red flags that you should note when a patient presents to office. Then recognize suspicious ultrasound features, then outline appropriate diagnostic workup, then just review some management principles. So I'm just going to start off with some couple of cases that I've managed. I think I've managed about 5 or so sarcomas in the past 4 or 5 years. So 53-year-old woman. And what I find very interesting is this: when they present, they've got a long list of symptomatic uterine fibroids. So she comes and says, oh, it's a patient with non-fibroids. She has been offered surgery and she had climbed. But when I then saw her, she now had cough and shortness of breath, which made me a bit suspicious. Was it anemia causing some heart failure or was it something else? Clinical examination, she had a 28-week mass, and systemically she looked unwell. The second case, I want also to concentrate on the age, 53-year-old, coming with fibroids. Then the next case, look at the age again, 61 years old, history of asymptomatic fibroids. So when you look at the card when they're coming to the clinic, known patient with fibroids, 61 years old. But now she said that the timing was growing very big in a short period of time. She has some systemic symptoms, cough, shortness of breath. In an examination, she had a huge 10-sized mass. I'll come back to this case at the end. So how common are uterine sarcomas? Of all endometrial cancers, they are less than 1%. And what is the median age of presentation? If you look at leiomyosarcomas, they present between ages of 48 and 55. So some of these women are actually perimenopausal during their periods. And if you look at the other sarcomas, adenosarcoma and endometrial stromal sarcomas, they present somewhere between the ages of 50 and 58. Just for the students who are writing this here, carcinosarcomas are not classified as sarcomas. They are classified as epithelial tumors of the uterus. So when you're writing essay, don't put carcinosarcomas there. And I think one thing to notice that these are very aggressive tumors with poor response to treatment. What are the risk factors? Therapy of radiation is associated with development of sarcomas. Tamoxifen exposure is associated with development of sarcomas. Hereditary retinoblastoma, with a mutation in the retinoblastoma 1 gene. Lipfrometic syndrome, TP53 mutation, and hereditary leiomyomatosis and renal cell carcinoma syndrome, where we've got the FH mutation. So these are some of the things to think about when you've got a patient with sarcoma as risk factors. So how do they present to the clinic? Just like any woman with fibroids, they'll have abnormal uterine bleeding. They'll present with some pain or in the pelvis or abdomen, and they will say that this mass has been rapidly growing over the past few weeks or few months. And just like fibroids, they have pelvic pressure symptoms, and they might be constipated because of pressure symptoms as well. So more or less, they're going to present like fibroids. And one thing that can then give the diagnosis away is that usually women with fibroids are healthy, they are fit, they don't have any systemic symptoms. But these patients, if you dig further, they might have weight loss, they might have fatigue, or they might have anemia. So when you see these patients in the clinic, what are the red flags that should make you think, is this a fibroid or is this sarcoma? So if a patient, you've known them to have a fibroid, and then you come and suddenly this fibroid was normal about 35 centimeters, suddenly over the course of a few weeks it comes, and this woman has got a 18-week uterus, and you see that this is rapidly enlarging. The patient is telling you that I got this mass, but now suddenly it's growing big. In a woman with menopause, if you make a diagnosis of a new or enlarging fibroid, it's a sarcoma until proven otherwise. Because I think if you go back to what I said today, normally we expect fibroids to become asymptomatic when a woman gets into menopause. And fibroids sometimes can cause pain, but if the pain is not really typical of what you normally see with fibroids, or if a patient has got abnormal or postmenopausal bleeding. What are the treatment? I think we've had a talk about using generic analogs. If a patient is on generic analogs and these fibroids in pot continue growing, be suspicious, and if someone comes and they have a previous prior pelvic radiation, also be suspicious, or if they've been exposed to tamoxifen. So I think whenever we see a patient with a uterine mass, we're going to start off by doing an ultrasound. And transvaginal ultrasound is the first line investigation. And it's very important then to distinguish on ultrasound what are the, is there anything suspicious for a sarcoma? So this is what you normally see when you scan fibroids. That you rarely see a solitary fibroid. I'm not saying it doesn't happen, it can, but normally fibroids, they are not full. And when you look at the margins, they are really well circumscribed. And they've got some, if you look at the echogenicity, it's homogeneous. And they usually have got some acrostic shadowing. And when you look at the vascular pattern, usually the vascularization is at the peripheries. On the pseudocapsule, you don't quite get interregional vascularization, and you don't quite get central necrosis. So this is kind of like a typical fibroid that you see every day when you do the transvaginal scan. What's on ultrasound to make you think that this could be a sarcoma? If you see a solitary lesion more than 8 centimeters, some literature will put a figure there of 5 centimeters, so 5 to 8 centimeters. And if you look at the echo texture, it's quite heterogeneous. And if you look at the margins, they are very, very irregular. And you see some cystic degeneration in the center, or whatever, what looks like some necrotic areas. Moderate high internal vascularization. Remember, we said that with a fibroid, it's actually on the vascularization on the periphery, but this is different. And you get this mass, there's no acoustic shadowing and irregular. I think I mentioned that before. And if it's a patient that you have been known for some time and they've been scanning here for other things, and then you suddenly see what you thought was a fibroid, now they've got rapid growth, especially when they are more than the age of 14, 50 years. I think these are some of the pictures. I think you do more, people who do scans. I think we are used to see the fibroids every day when you put in the transvaginal. So I think we said when fibroids, you normally see this homogeneous echo texture, but with the sarcomas, this is kind of like what you see. There's some heterogeneous echo texture. Isoechoic, hypoechoic areas. So it's not. So this is what I was talking about. If you look on the left, on the left, that's a fibroid. You see a bit of vascularization on the peripheries, which is a complete different picture which you see where you've got a sarcoma. There's a lot of vascularization which is just not on the peripheries. So if some necrotic cystic areas that you might pick up when you do the scan. And compared to a fibroid, you've got this irregular, very ill-defined margins, whereas the fibroid, these margins are quite well-defined. And absence of acoustic shadowing. So I spent some time talking about the vascularization. And these patients that we normally see, the radiology said that I'm not worried about this vascularization. This mass is very, very vascular. I'm worried that this could be a sarcoma. So when you look at the vascular pattern, when you do the ultrasound, it gives you some important clues. I've already spoken about this. Circumferential flow, which is typical for benign, and central aortic vascularization, which is suspicious. So normally they'll come to you because of that suspicion of vascularization on ultrasound. But how predictive is this? So if a patient is referred to you and this fibroid is very, very vascular, how many of those patients end up with a leiomyosarcoma? So if you look at this study, they looked at all patients that had a diagnosis that had very, very vascular masses, and then looked at the histology. 45% of them ended up on the final histology, the typical fibroids. Another 40% had different variants of fibroids, cellular, myxoids, apoplectic, and another 5% listed out to have adenomyomas. So out of these women who will be referred to you because the radiologist is worried about this vascular pattern, only about 7% of them will turn out to have a leiomyosarcoma. So vascularization alone is not diagnostic, but I think it just raises some suspicion. Another study, they took women with historically confirmed leiomyosarcomas and again went back and looked at the ultrasound findings for those women. They had large tumors, most of them more than 8 centimeters. They had heterogeneous appearance, there was cystic degeneration, moderate high vascularization. But look at that number on the bottom. Only 50% of them were suspicious on ultrasound. That means the other 50%, there was nothing suspicious about them, and the radiologist will happily call them, or the gynecologist scanning will happily call them a typical fibroid. So I think even after you've done ultrasound scan and you're worried that this could be a sarcoma, you still have to do some more evaluation. So if there's suspicion of a sarcoma, the next step that you're going to order is an MRI scan. This will characterize this further. And all these patients, especially if they've got bleeding, then you can do an endometrial biopsy. I saw a study where when they did a biopsy on women when presented bleeding and the sarcomas, about 82% of them actually picked up on the endometrial biopsy. And when the cystoscopy is indicated, then it needs to be done. And if there's metastatic disease on your initial report, then you can do a CT. If you've got facilities which you don't have, you can then order a plate. So when you suspect a fibroid, which is still, when you suspect a sarcoma, which is still confined to the uterus, primary treatment is surgical, and the aim is complete tumor resection. This is a hot topic. Avoid mutilation when malignancy is suspected. So when you see these suspicious, even if your features on ultrasound or MRI, even if your biopsy is negative, then decides to do a hysterectomy. These are the patients that you don't mutilate. Find other ways for tissue retrieval. So once surgery has been done, nothing works for sarcomas. I think everyone in this room is well aware of this. Chemotherapy doesn't work. Radiotherapy, maybe some selected cases, but as a general rule, doesn't work as well. And hormonal targeted therapy remains controversial. So I think the best shot for these patients is surgery if they present with early disease. So I think everyone who practices obstetrics and gynecology should know about this woman called Dr. Amy Reed. She was an anesthetist working at Beth, this is our Deaconess Medical Center in the United States. She was a lecturer as well at Harvard University. Very young, 41 years old, she presented to a gynecologist with abnormal uterine bleeding. She had an ultrasound scan done. Nothing suspicious was picked up. They did an endometrial biopsy as per the protocol for the hospital. Endometrial biopsy was negative. They then took this patient, mother of 6, took her to theater and did a beautiful laparoscopic subtotal, or some people call it supracervical hysterectomy. Power mutilation was done, went home, she was happy. So she came back, and when the histology came, then they found out this patient had leiomyosarcoma. So They then did imaging and found out now that she had disease everywhere because of dissemination of tumor with the power oscillator. They tried a lot of treatments, surgery, resetting all this disease, and trying to put her on chemotherapy. But 3 years down the line, she succumbed to this disease. The husband was a cardiothoracic surgeon, and he raised a lot of hell. And that led to FDA in the States and most of the countries initially cautioning the use of power oscillation in some jurisdictions. It was banned. So I think we should always think about this when we do power oscillation. When I've got a young patient less than 40, data shows us that risk of it being a sarcoma is very low, maybe close to 0. But when you've got an older women, think 10 times before you do power oscillation. If you have to do it, then you have to really get consent, and you have to do it within a day. So I think slowly look at what Dr. Aole presented. I think the days of just doing power oscillation outside the tissue containing system, I think those days are. So I think this led to a very global change. So out there in the world, a lot of people are cautious before they ask to get a power oscillator for some of these patients. So what happened to those patients that I presented at the beginning? The first patient, she had a multiple canonical lung metastasis. And I said that the beginning she had a 28-week mass. When you've got metastatic disease, you don't operate. You then do an image-guided biopsy and confirm that she had a leiomyosarcoma. Remember what I said, neoadjuvant and adjuvant chemotherapy doesn't work. But as doctors, we feel that we have to do something. So the oncologist recommended neoadjuvant. She developed small bowel obstruction, underwent the palliative THPSO. There was a ruptured 30cm fundal tumor, which was uterus and ovaries were removed. She declined adjuvant therapy. I don't blame her for that because it doesn't work. It's sort of alternative therapy in South Africa. It's a very, very expensive thing. I didn't know that this alternative treatment just doesn't comes at a very, very high price. Unfortunately, she came back very sick and succumbed to the disease 12 weeks after surgery. Same case, what happened to case number 2? Multiple biliary lung nodules with large adnexia masses. We also metastatic disease. We don't operate these patients. We did an image-guided biopsy, confirmed the leiomyosarcoma. This one opted to receive neoadjuvant therapy, which doesn't work. So she had an image and submission to the infection and also intolerance of breath, and died at home 6 weeks after referral. So what are the key take-home messages? Leiomyosarcoma is rare, but it's very aggressive. Always consider it in peri or postmenopausal women. I always fight with my registrars when they are presenting a peri or postmenopausal patient to me, and they say, patient no need fibroids, and the plan is to do a hysterectomy, no endometrial sampling, no review of ultrasound. I think always think about the possibility of a sarcoma in peri or postmenopausal women. If there's rapid growth or atypical imaging findings like what I just presented to you, and it's very important because a correct diagnosis changes management for these patients. You don't then, because if you don't get the correct diagnosis, these are the patients who are saying, oh, she's got a fibroid. Take them to theater, remove the fibroid, they remain sick. When you then do scans after that, you find out that they've got disease everywhere. Spread for this disease is hematogenous, and metastatic disease is common in advanced disease. I've already said they're not responsive to treatment. And I think one of the best things in oncology is personalized treatments with targeted therapies, but they are not non-targeted therapies that have been shown to work for performance. So in conclusion, uterine sarcomas can mimic benign fibroids. So you should always have a high index of suspicion when evaluating women referred with fibroids. In quotes, early diagnosis significantly affects treatment and prognosis. I presented the case of Amy Reed, published a disease confined to the uterus, and if she had had the proper surgery, probably things might have turned out different, but she died 3 years after a simple hysterectomy. So what I found, it's anecdotal, I don't have any data, but in our setting, most women present with advanced disease and metastatic disease. So can I leave a pelvic cue? So if you've got a woman with a uterine mass or a pelvic mass that have got metastatic disease, it's a sarcoma and to proven otherwise. Normally, ovarian masses, I'm not saying they don't, but they really present with metastatic disease. So a mass, especially uterine, with metastatic disease, it's a sarcoma and to proven otherwise. This should be my last slide. I think those are some of the references that I use for my talk. Thank you for taking time to listen to my